Okay, everybody, we're going to get started again. We're really pleased to present Dr. Melanie Smith here from Northwestern Medicine, and she is going to be speaking about palliative care.
Hi, everyone. I'm Melanie, so I'm one of the palliative care doctors. I see patients in the hospital and in clinic, and I have an interest in palliative care for adolescents and young adults. And today I'm presenting on palliative care, managing the symptoms of cancer and its treatment. Okay, this is my first time using this thing. And if I need to speak up, just, motion, because I know I have a soft voice. Okay, so I have no disclosures except I do work for the clinic. So if you come see us, I do benefit in some ways. Okay, so palliative care, let's just air out what you've heard, what scares you about that term. Yeah. Go ahead. Mm-hmm. Definitely. I think that's an assumption from patients and from doctors. Anything else people have heard? Yep. Yeah, I've heard a lot of both from patients and from doctors, like an assumption that when palliative care is involved, all someone cares about is comfort. Like it signifies a transition in their care, and that's just not true. So I wanted to air that out here. And I think this cartoon kind of shows the perception a lot of people have, and that's how I feel in the hospital sometimes, because it's certainly not just patients and their caregivers and their family that feel that way, it's doctors too. But it's changing. So palliative care is not hospice. Palliative care really focuses on the relief of symptoms and the stress of serious illness. And I want to really stress this, it's appropriate at any age and any stage. So it's provided along with curative treatment, along with cancer treatment. It's just appropriate for patients who are suffering from a chronic serious illness. And it's interdisciplinary. So you're not just getting a doctor when you get palliative care. There's nurses, social work, pastoral care, volunteers, and palliative care at kind of every institution has different interdisciplinary members. Those are our members here. Other places also have psychologists. What are other things that other places have? We have a lot of learners as well, but a lot of different team members, like massage therapy can be part of palliative care, acupuncture. Here, I think we kind of group a lot of those under supportive onc. Okay. So what do we really do? So I'd say number one, what we do and why we get involved with most patients, especially on the outpatient side, is symptom management. So as a palliative care doctor, I got a lot of extra training in symptom management, more than your cancer doctors. So I'm just a little better and a little more focused on treating symptoms. Psychosocial, spiritual support. So, you don't just have physical symptoms when you have cancer or a serious illness. It's really hard. Our job is to support you, and it's not just to support your physical symptoms or to treat your physical symptoms, it's to really support you and your family as a whole. And that means we can work with the patient alone, it means we can work with the caregivers or friends and family alone, or we can see you all together. But we want to treat everyone that's part of that patient's kind of care team. I'd say we also are experts in home care. And we'll go into that a little bit more, but that's something we can be really helpful with. A lot of times we get the consult, like, we want to see what palliative care can offer you. Like, we have like this menu of services, which isn't really true, but I think it goes to the fact that we know a little bit more about what can be done at home and what's realistic. And sometimes, unfortunately, that's telling people what is not available, which can be really hard, but at least I think we can give people straight answers and the right expectation. And then the other thing we do is advanced care planning and goals of care discussions. And again, we'll go into that a little bit more at the end of the presentation. Okay, so where do we see patients? Here we have an outpatient clinic. And this is an expanding part of our practice. So we're shifting more from inpatient service to the outpatient clinic. Most of our patients are seen with oncology. Since this, audience is mostly going to be an oncology audience, I'm going to focus mostly on how we see oncology patients. So we see patients either in the office with the oncology team or during infusion. And that means we have pretty close relationships with everyone in the cancer center. We do similar programs with pulmonology and cardiology, but I'd say it's most developed with the cancer center. And then we also have a separate clinic space. So sometimes you're not getting your treatments very frequently, or you're not seeing your oncologist very frequently, but you need you need your symptoms addressed more quickly than you're going to see the oncologist. So we can see you in a separate clinic space. Of course, it's still like a cancer clinic space, but we have room and availability to see people there. And then we have an inpatient consult service. So if patients are admitted, we will see patients during their admissions, and we focus on the same things there as we do in clinic. We also try to keep the same provider. So if we know you from clinic, the same provider will try and see you in the hospital. It's hard, so we're not always able to do that, but we try. And at minimum, we're talking to the team to let them know what's been going on in clinic and to try and provide continuous care. Okay, so symptom management. So sometimes I really do feel like a pill pusher. And I know you guys, or most of the patients here, probably feel like you're getting way too many pills. But some of those pills are really essential to managing your symptoms and to doing well. And I think, so there have been studies that show that patients who get palliative care earlier in their treatment live longer, live better. And I think this is a big part of it, is that when you feel better, you can tolerate more treatment. I know why you feel better. You feel better. You have better quality of life because we're helping you feel better. We're supporting you. But the living longer, I really think, is you're able to tolerate more treatment and live better. Okay. So I'd say we focus on a lot of symptoms. We get training in a lot of symptoms. These are the major ones, and it's a lot. I'm sure you guys know better than I do how much stuff can go on. Okay. So I'd say the main thing we talk about in clinic is pain. So pain is definitely the number one complaint. And not only is it the number one complaint, but that's often why people refer to us, like they need help managing the patient's pain and they know we can do this. Also, a lot of providers don't love prescribing opioids, and they know that we have training in it and we're comfortable with it. So the mainstays are medications. Just like any other doctor, we're going to try and get by with medications that aren't addictive and aren't sedating. So we're going to start with anti-inflammatories. We're going to start with neuropathic agents. But most of our patients need opioids. That's why they were referred to us. But we don't just push morphine. We try and get by with the lowest possible doses. We're also not scared to give high doses if that's what you need. And then with opioids, we need to see patients frequently, not just because you have severe pain, but because you need the medications in a paper script. It's hard to get them from the pharmacy, but we'll see you closely, monitor for side effects. And meds aren't the only things that we can do for pain. So for instance, just yesterday, I saw a patient who was having worsening leg pain, looked through the scans. I did increase his meds, but I also referred him to radiation because he had a lesion in his leg, and I think radiation could really help his pain. So we're not just going to push opioids, we're going to look for other modalities. We also have a pretty close relationship with anesthesia. So they see our patients more quickly than they see their average patient. We get steroid injections, we get nerve blocks, and we get intrathecal pumps. Especially the steroid injections and the nerve blocks can be really medication sparing. So I have a patient who had really difficult to control abdominal pain. Every time I saw him, he was pacing around and he really hated the morphine because he got nauseous. He felt out of it. He got a nerve block, no longer on opioids. Walking around feels great. I mean, that's not something I did. That's what the nerve block did. But, we're happy to do those procedures if they think they will relieve your pain and we think that they can reduce your medication needs. And then, as a lot of you probably know, hand in hand with medications for pain control is constipation. So I'd say the nurse that we work with, we say most of what we do is pain and poop. So when we start opioids, we also start medications to prevent constipation. I think that's part of the reason I feel like I'm pushing pills, because when I give one, I'm always giving the other. So we do a lot to prevent, but we also do a lot to treat, because that symptom is going to change. Although a lot of the other symptoms or the other side effects you get from opioids go away with time, like the sedation and fatigue and nausea usually go away with time. Constipation does not. So we are aggressive in our bowel regimens. Sometimes things don't work and you need adjustment. We have a number that you can call. It's only during work hours right now, but we can make a lot of adjustments and give a lot of advice by phone. Okay. So I'd say these are other major symptoms that we treat. Again, the mainstay for these symptoms are medications. And I think one reason that we are effective in treating these is because, first of all, we have the time and this is our focus. So we really listen to what is causing your symptoms. We're not always going to know, but we really think about, why is this patient having nausea? Is it because the chemo? Or is it because something's going on in the GI tract? So we really think about it and we try and choose the medications based on why we think you're having those symptoms. So I think I know we can be very effective in treating these symptoms. And I also want you to know that, like, if we are effective in treating your symptoms and you want to back down on meds, we are also happy to help you back down. So it's not like once you start these meds, you're on them forever. We are working with you and we want the same things that you want. I also want to point out that though medications are our mainstay, even for these symptoms, we work with other providers. So I'd say a good example of this is our relationship with physical medicine and rehab people. So we have a pretty close relationship with RIC and their cancer rehab program. And a lot of patients with fatigue and weakness, we refer to our two colleagues over there who do cancer rehab. And I've seen really good success with physical therapy and rehab for patients with fatigue and weakness. And sometimes it's something your oncologist would think of, but because of that relationship, sometimes we think of it first. Okay, and then anxiety and depression, another major symptom that we treat. So we treat a lot of that on our own, mostly using medications, but we also work closely with supportive onc, so the psychiatrists and psychologists and social workers and supportive onc. And we try and manage with them. Like I was just talking to Stacy about a patient we have in common. And we can also help identify resources closer to home, because I know that the cancer center is not convenient for everyone. So we try and find colleagues, find practitioners closer to home if you're not coming to Northwestern frequently, or if you just want someone closer to home. Okay, so I'd say this is another major thing that we do is support. So this is not us, right? Our role is to listen to you, is to support you, is to hear about what you're going through. Sometimes I like to remind people, like, this is really my job and this is what I get paid to do. So I don't do it because I get paid to do it. I do it because I enjoy it, but I want to hear what you're going through, and you don't need to sugarcoat it for me. This is what we're here for. So some places call the palliative care team the supportive team. So that's really how we view ourselves, as an extra layer of support. I like to think that we help communication between providers, and that we're really the people that you can turn to if you need someone and if you feel like you're not being heard. Again, it's that interdisciplinary team. So, you don't just need one type of support. You don't just have one type of symptom. You can be you have the physical symptoms, but you can really be struggling emotionally, socially, spiritually, and that's why we have different providers. There's definitely some crossover. Of course, like, I'm an arrogant physician, so I think I can do all of those things, but slowly I think I've realized I can't. We have a chaplain because he's really good at spiritual support, and he's able to connect with patients that I can't connect with. Same with our social workers. So sometimes it seems like a lot of people, but I think each person is an opportunity for connection, an opportunity for support, and you can always say no. You can always send us out of the room. I think it's pretty hard to offend us, or at least it's pretty hard for us to act offended. We might do it behind your back. And then again, I think I said this before, but we want to support the patient and we want to support the family. So we can meet individually, we can meet as a group, and we're happy to do both. Okay, so this is kind of an example of the things we talk about, the things we want to hear. Just to reemphasize that we want to hear these things and we want to address them. So I'll ask questions like, what are your fears? What's bothering you? What are you worried about? What are you really hoping for? What's important to you? And I don't know that you're getting that opportunity with every doctor. So that's what we want to do. I wondered if there are other things that you personally have felt that you've wanted to talk about with your medical team and just haven't been able to, because maybe there's things I'm missing on this list that I should be asking. And this might be too personal of a question, but okay. Okay. All right, so another area of expertise is home care. So just because of palliative care's relationship with hospice and the fact that we do care for a lot of patients near the end of life, we know a lot about what can be offered at home. And I think the other reason I think we're good at this is because I actually forgot what I was about to say. Or I think the other reason is because we work so closely with social workers, and this is often a big part of our planning sessions is what is feasible. We also spend a lot more time with you guys, so I think we can identify what needs there are at home. So we frequently set up home nursing, get medical equipment, get home PT and OT out. So I think especially our nurses are really good at identifying those needs and things that other people just aren't picking up, because a lot of providers don't do that much care at the home, so they don't know what kind of things people really need. We also help people identify a need for a caregiver or nurse's aide. I said it before, I'll say it again. Sometimes it's telling you, insurance doesn't cover this, but I think you need it, and finding creative ways to get it, and thinking about how you can get friends and family to fill those needs if we can't afford them. Okay. And then finally, advanced care planning and goals of care. I think this may be where a lot of the fears come from. And I think there's also a lot of confusion about those two terms. So goals of care, it's really simple. What are you hoping to achieve with treatment? What are your goals with your treatment? And there isn't a right or a wrong answer. That's the other problem, is when people get palliative care involved, they think the goal of care has to be comfort. But no, the goal is whatever you want. It's our job to work with you to help achieve that goal. So these are all goals that I've heard. So cure of disease, definitely the goal I hear most frequently. I want to get better. I want to get over this cancer. I hear a lot the feeling good for an event. So I have a graduation I really want to graduate, and I really want to feel good that day. So then if I hear that, I'm going to work with the oncologist and the other care providers to maybe take a break from treatment the week leading up to graduation, maybe use some meds that day to make you have a little more energy, some temporary things just to get you through that day. Same thing with birthday parties. I know I had a father whose kids were both had a birthday within 3 days. It was a huge party. He wanted to feel really good on that day. We made him feel pretty good that day. Maybe a little too hyper, but he had been really tired, and that was important to him, and I felt really good that we could make that happen. So maintenance and improvement on function, also a totally reasonable goal and something we would work with you to achieve. So quality of life. I think this is when they usually start getting us involved. Relief of suffering, life prolongation. So sometimes people know I can't cure this disease, but I want to live as long as I can. That's another reasonable goal. Independence, a good death, staying in control. Another thing I hear a lot is that avoid being a burden, which usually that leads to a big discussion about, what does that really mean? But again, we will work with you to help achieve these goals. So, and there are some caveats, and we'll talk about them. So again, your treatment should align with your goals, but goals change over time. Goals change based on your disease, based on how you're feeling. But those are the two things that I think usually make your goals change. And goals can be unrealistic. So, So if your goals are unrealistic, so if you have a disease that we know is not curable and you want to cure that disease, my role is to try and clarify any medical misunderstanding. So make sure that the patient knows that we don't think medically we can cure that disease. We can't rule out a miracle. No one can rule out a miracle, and I can't prevent a miracle. So I think that's fine to hope for that. And I want to support that and know that that's what you're hoping for. But I also want to help you come up with a plan B. So, knowing that most people don't think you can be cured, what other things are really important to you and what other things can we focus on? And I'll still try and come up with things that work for you. So again, it's not changing your goals. It's trying and finding mutual goals and making sure our treatment aligns with those goals. I think, again, often we get involved when providers want your goals to be comfort focused, but that's not how I see my role, and I know that's not how the rest of our team sees our role. So we want to honor what you're telling us. Okay, so advanced care planning is really simply making plans based on your goals, based on your values. So, and they're to ensure that your wishes and preferences are honored if you are unable to speak for yourself. I'm close to running out of time, so I'm going to go a little quickly on this part. Mainstay, power of attorney for healthcare. So this is the person you kind of nominate, you trust to speak for you if you are unable to speak. And that means speaking for you. So that means they know your values and preferences. They will make decisions honoring your wishes. It requires a witness. So the witness can really be anyone except your doctor or your nurse. So it just can't be a healthcare provider. Realistically, in the hospital and clinic, it's a volunteer, a social worker, or a chaplain. But it could be your neighbor. This is something we really advise for people to do because, there are moments where people are likely to be confused, be sedated, and it's not necessarily permanent, but we've all been there when there are times when we even don't want to make decisions on our own behalf. And, for a lot of us, that's minor decisions, but I think it's a good idea to have just as a plan B. So we really encourage all of our patients to do this. And when you do it, discuss what's important to you. And if what's important to you changes, update that person. Okay, 5 wishes. What I'll say about this is it's a more detailed advanced care planning document. There is a portion where you can nominate your power of attorney. I don't think the document's very clear that it still needs a witness, but so with that caveat, 5 wishes is a really great way to explore your wishes, what's important to you, what kind of treatment you want, what kind of treatment you don't want. And those are available in the Cancer Center. Finally, POST, they're physician orders for life-sustaining treatment. These are physician orders, so they must be completed by a physician. They're orders that go with you from clinic to home to the hospital. And they're only for patients with a serious illness, and they're only for patients who have decided to set limits on their treatment. So these are for patients who have decided they don't want attempts at resuscitation, or they don't want to be admitted to the hospital, or they don't want to go to the ICU. So, you know, these may not apply to you at all. Okay, and then one last thing is to make the most of your palliative visit. If you do see us, bring a list of your symptoms, your questions, your concerns. Consider bringing the person who helps you make decisions, who helps care for you. And if you've already done some advanced directives, bring them with you. I think I talked about this, but that's just a summary slide. We want to help you manage your symptoms. We want to help support you at any age, at any stage. And you don't just have to see a doctor. We have a lot of people that want to help. Okay, questions? Yeah. You're asking when should you ask your oncologist to refer to us? It depends a lot on the oncologist. So some of them work more closely with us than others. I think if you think you would benefit from palliative care, it's something you could ask. Most doctors aren't going to be offended. You could say, you know, I've heard a talk about it, I've done a lot of reading, and I'm interested in meeting with the palliative care team. And if they ask why, tell them why. You know, it's a lot of oncologists, I mean, they want our help, right? But they don't want you to feel like they're giving up. And I think that's a lot of the fear of referring to us, because they know we have kind of that reputation. And we're trying to dispel that reputation, but that may be why some of them are hesitant to refer. Am I okay to answer? Okay, go ahead.
So you mentioned your involvement at the very beginning and then also at the end as a serious illness, right?
Yeah.
Is there a prerequisite for when you get involved? It kind of piggybacks her question, right? You know, obviously asking is one thing, but is there a line of when, you know, you're able to get involved and when you're not by defining it seriously?
Yeah. So it's a hard thing for us to define, and it's something as palliative care doctors we struggle with. I think of serious illness as a illness that can be debilitating, that carries a higher risk of death, has a high symptom burden. So those are kind of my prerequisites. We do make some, go ahead. I actually cannot comment on the new ESCA recommendation.
There's this new recommendation where really they're encouraging earlier involvement of palliative care with any patient who has stage 4.
Yeah.
So there's actually some literature evolving showing that people actually have better outcomes if they have palliative care involved earlier in their care than later in their care, and they make some recent recommendations. So my bias, I'm a psychologist, but my bias is earlier though better to at least make that connection in case you need.
Yeah. So stage 4, definitely, because the evidence is very clear that we improve symptoms, improve length of life. There is sometimes it can be hard if patients are cured of their cancer to see us, because we do have a focus where we you know, like we use a lot of opioids and we don't want you to be on them chronically, but we certainly will see you for a visit and we'll work that out with you. You know, we're not gonna, and if we think, hey, no, this patient really isn't appropriate for palliative, like they just have chronic back pain, and I'm not saying just have chronic back pain. I know chronic back pain sucks, but if it's not due to some other serious illness, then we won't see them, but we will work with you. And if there's a reason you really want to see us, we'll talk to you about it and try and figure it out. So there's no black and white. Okay. Thank you guys. I'm sorry I ran over.